We're recording this meeting for those who can't make it. I know this is a very, very busy time of the year for everybody, and we've already got some of our clients and some of our billers on vacation, but I want to make sure that everybody has access to this very, very important information that is going to affect you and your practice in 2017 and in the years to come. So what we're talking about today is MACRA and MIPS, what you need to know. And I hope that all of you know who I am. My name is Lisa Majeski. I'm the president of Gold Star Medical Business Services. This is an invitation-only webinar, and I have invited my clients and some of the friends of Gold Star Medical who have been with me and following Gold Star Medical for a long time. We've sent an invitation out to a few non-clients as well, but basically this is for our clients, and what I want to do is I want to make sure that every single one of us who have contracted with Gold Star Medical to provide your billing services understand the ramifications of the new MACRA law and how that is going to affect your reimbursements again in the years to come. So without further ado, we'll go ahead and get started. And what we're going to be talking about today is the Quality Payment Program, which is now the program that as of January 1st is going to be replacing for Medicare Part B the traditional fee-for-service program that we have operated under since basically the beginning of time. And so let's talk about a little bit of background on this program and how it came about. Just want to give you a little bit of a backstory. First of all, I do want to let you know that the materials that I've included in this presentation come directly from Medicare documents and Medicare educational documents and programs that they have. And this program, the MACRA law and the implementation of MACRA and the MIPS, or the Merit Incentive Payment System program, is changing, and it changes rapidly, and it's very, very fluid. And so the presentation information that I have is the most recent that I could find on the Medicare website. So there may have already been some changes that have taken place. I don't think so. I've tried to keep up as much as I can with the updates. But just so you know, this is this is not the law. This is not intended to take place of the law. These Medicare policies are going to change frequently, so we have to make sure that you understand that it is going to be up to all of us to keep up with the updates and changes that are taking place through this new payment model. So let's talk about how MACRA actually came about. So what we operate under right now with Medicare and with most insurance companies is what we term the fee-for-service payment system. And basically, on a fee-for-service payment system, you have a service that you provide a patient. That service is assigned a value, and then when you bill that to an insurance company or you bill that to Medicare, that value is assessed on the service. The patient benefits are then extracted from your payment. So if the patient has a copay or there's a deductible, then that amount is extracted out of the bill as patient responsibility, and then the insurance company basically pays the balance of the claim. In 1997, Medicare basically approached and CMS approached Congress and said, look, if we continue with Medicare the way it is right now and with the payment of Medicare claims, we're going to go broke probably within the next 10 years. And of course, Congress reacted very rapidly with a bill called the Sustainable Growth Rate Bill. And the SGR was established in 1997 to control the cost of Medicare payments. So essentially, if overall physician costs were greater than targeted Medicare expenditures, then the physician payments would get cut across the board, regardless of the quality of service that physician provided. And so and basically, you know, the medical community went into such an uproar, and I don't know if some of you were in practice during this time when the SGR was under, you know, under the microscope for implementation. Um, the medical community went into such an uproar. There were campaigns through the AMA, through state associations, through physicians groups and IPAs, to write your congressman and let your congressman know that if they went forward with the SGR, that doctors would opt out of Medicare, which of course we know chiropractors cannot do, but the medical community said, you know, we're gonna as a whole opt out of Medicare, and you're just not going to have enough doctors to service your Medicare patients. And so of course Congress then had to react to that. They were placed between the proverbial rock and a hard place, and they created temporary fixes each year to avert the cuts. So, for example, based on the overall physician costs and the targeted Medicare expenditures for 2015, if there had not been a doc fix to avert that cut in 2015, all doctors would have received a 21% cut in Medicare payments. So what happened over time is the physicians groups essentially through congressional hearings began to express to Congress that we should not as a whole be penalized on the bad behavior of a few. So, you know, we know that there is a small percentage of physicians and physician groups and entities that essentially create most of the waste, fraud, and abuse within the Medicare system. The majority of the doctors out there are doing a good job. They do not overbill. They do not, you know, they do their documentation the way they should. And so the doctors were saying, look, we should not be penalized. If we're doing a good job and we're providing quality service, we should not be penalized. Go ahead and penalize the ones that aren't. And so through programs such as Meaningful Use, PQRS, through the implementation of Obamacare and the PPACA, we began to move and morph into the template of rewarding physicians for quality, measurable quality care versus the quantity of care. And in 2015, in April of 2015, the SGR was repealed and it was replaced with MACRA, and part of MACRA was the acronym for MACRA is the Medicare and CHIP Reassignment Act. It repealed the sustainable growth rate formula. And basically what it did was it took the multiple quality reporting programs such as PQRS and Meaningful Use, the value-based modifier, and then moved it into one program that would streamline all of that reporting. It also allowed to provide significant incentive payments for participation in advanced alternative payment models, but also gave individual doctors, you know, if you're not in an ACO or an accountable care organization or a large group and you can't participate in an alternative payment model, it gave an opportunity for individual doctors to allow themselves to be reimbursed at a higher level, even as an individual. So the quality payment program for Medicare is really the first step to a fresh start in the way we're going to be reimbursed starting in 2019. Medicare is continually listening for feedback on this program, and so we are still in, even though the final rule on this program has been published, it is still open for comment and feedback. Medicare is listening to the programs that have been implemented as part of the PPACA to provide a healthier Medicare population okay, and to pay for what works to create a Medicare that will endure and that won't essentially go broke, okay? And so the quality payment program is affecting us in a number of ways. And right now, the way the Medicare reporting prior to MACRA was that you reported PQRS, which was the Physician Quality Reporting Program, the value-based payment modifier, which was assessed based on your claims and your usage of codes, and then the Medicare EHR incentive program, which we know is meaningful use. Well, now all of these three programs are rolled into one, and that one is called MIPS. And MIPS is a new program. It streamlines three currently independent programs to work as one and to ease clinician burden. It is also adding a fourth component, which is new, to promote ongoing improvement and innovation to clinical activities. And what MIPS is doing is it's providing clinicians the flexibility to choose activities and measures that are most meaningful to your practice to demonstrate performance. So it's giving you a little bit more creativity within your performance measures. Okay. Affected clinicians who will participate in MIPS. These are called MIPS eligible clinicians, and these clinicians will participate in MIPS. The type of Medicare Part B eligible clinicians that are affected by MIPS may expand in future years. So in years 1 and 2, which year 1 of MACRA and MIPS is 2017, January 1st, which is just a couple of weeks away. This will include physicians, PAs, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, and also note here that physicians mean, and it gives all the descriptions of physician, and that does include a doctor of chiropractic legally authorized to practice by a state in which he or she performs this function. So we are lumped in with physicians as eligible clinicians to participate in this MIPS program. Now understand, you know, some of you I know are listening in, and some of you may have not participated in PQRS and in meaningful use, or maybe you participated in one but not the other. And I've heard doctors say, I've been out teaching this now for several months, not just to chiropractors but to physicians at hospitals and large hospital groups and large accountable care organizations. And I have doctors tell me all the time, well, I'll just take the 2% cut, you know, this isn't worth it. And so what I'm trying to get across here is that this 2% cut is going to affect you over the next couple of years because of what you have done as far as participating in meaningful use and PQRS in 2015 and 2016. Those will affect your reimbursements in 2017 and 2018. But basically, MACRA is a mandate. It's law. So it's not something that you can or cannot participate in. If you don't participate, the cuts that Medicare is anticipating will be significant. And we will see later on in the program today that that it's not only Medicare that is going to be affected by this type of a payment model. We already see that commercial carriers are following suit, and I'm going to be showing you some examples of programs through Blue Cross and Cigna that are already tying payment to value of service. And so even if you're listening and you say, well, I see so few Medicare patients, this really isn't going to affect me. Yes, it is. And so what I want you to do is I want you to listen carefully to the criteria for participation and the possible penalties for non-participation, and understand that that criteria is eventually and already maybe spilling over into commercial claims, Medicare Advantage claims, and so on and so forth. In the first year of MIPS participation, the only carrier that will be affected directly by MIPS is Medicare Part B. So what you need to make sure you do is you need to make sure that you are thinking in terms of, in this program, Medicare Part B only. However, as I mentioned, you've got to make sure that you understand how this program works so you can then apply some of the concepts to your billing practices and your reporting practices within Medicare Advantage and also within commercial claims. So in years 1 and 2, which is 2017 and 2018, MIPS is going to include chiropractors. In years three and moving forward, they may add physical or occupational therapists, speech language pathologists, audiologists, nurse midwives, clinical social workers, clinical psychologists, dietitians, and nutritional professionals may also be included in broadening the eligible clinician group for MIPS. There are 3 groups of clinicians who will not be subject to MIPS, okay? And it's important for you to know this because some of you may actually be not eligible to participate in MIPS. Number 1 would be if you're in your first year of Medicare Part B participation. So if you're listening to this and you're a brand new doctor, or if you are brand new as far as signing up to be a Medicare physician, then you would not be eligible to participate in MIPS in that first year. But the second and most significant one that will probably affect a good number of chiropractors and chiropractic clinics will be that you would not participate in MIPS if you fall below the low patient volume threshold. In this original publication, the low volume threshold was if you bill less than $10,000 in Medicare charges and provide care for 100 or fewer Medicare patients in 1 year. Since this publication, that amount has increased to $30,000 a year. So if you bill $30,000 a year or less in Medicare charges and provide care to fewer than 100 Medicare patients, and remind you that I'm not talking about patient visits. I'm talking about individual Medicare patients in 1 year, or you've billed less than $30,000 in Medicare services, then you would not have to participate in MIPS, and you would not have the same reporting requirements, which, you know, for a lot of doctors is good news. On the bad side of that, if you don't participate, then you're not going to be eligible for the increases. You just won't be subject to the pay cuts. You would just be placed on a neutral track, and you would get paid based on the Medicare fee schedule. Also, certain participants in advanced alternative payment models, and right now DCs don't currently participate in APMs, so DCs are going to be following by and large, unless you are associated with a large group and are the DC within that large group that participates in an APM, you're not going to be participating in APM. So I'm not even discussing APMs in this presentation today, just because the majority of us are going to be participating in MIPS, which again, MIPS stands for the Merit Incentive Payment System. Okay, so here's what we're looking at as far as what your payment adjustments will be moving forward. So we know that, you know, based on the PQRS and meaningful use participation that we have done or not done over the years, if you participated, let's say, to this year in PQRS and meaningful use, and you qualified for the payment adjustment for 2018, what you did this year would affect you in 2018. So everything is 2 years ahead or 2 years behind, so to speak. So for next year, for 2017, this model is not going to affect you. Nothing is going to be affected under MACRA until 2019. We're still going to be working under the old PQRS meaningful use model through the end of 2018. So we're sort of in a transitional phase right now where next year you'll be reporting MIPS, but you won't see the benefit of it for 2 more years. However, if you don't report next year, then what you can expect to see is a negative 4% adjustment. Oops, I'm sorry, I went too far. Let me go back up here. You could expect to see in 2019 a negative 4% adjustment, in 2020 a negative 5% adjustment, in 2021 negative 7%, and then in 2022 onward a negative 9%. And and we're talking about the negatives here, okay? So if you look at the blue arrow that is cross-cutting the purple arrows, the blue arrow represents the Medicare fee schedule, okay? And the Medicare fee schedule, I'll show you how that's going to work. Basically, starting in 2019, the Medicare fee schedule is not going to change. It's going to be set, and it's going to be set for the next 5 years. So if you're placed in the neutral track, so for example, if you're a low volume doctor and you meet the low volume threshold to where you do not have to report, you would not be subject to either the 4% positive or negative adjustment in 2019. You would just receive your payment based on that Medicare fee schedule. But for those of us who are eligible, okay, who are billing more than $30,000 a year and are seeing more than 100 Medicare patients in a year, you would be subject to either a negative or positive. So on the good side is that if you are reporting and you are utilizing EMR and you are reporting your quality measures, then you would be subject to pay increases of anywhere from 4 to 9%, and this is going to be significant. So you have a potential maximum adjustment of 9% within the next 5 years or so, which is definitely a good thing. So here's how the fee schedule updates are going to work. In 2015, there was a 5% increase to the fee schedule. In 2016 through 2019, there will be 5% increases to the fee schedule, but starting in 2020 through 2025, there will be no increase in the fee schedule. MIPS and the alternative payment models will drive payment from 2019 and onward. Beginning with calendar year 2026, they're anticipating a 0.75% update to the APM and the fee schedule, and a 0.25% update for other physician fee schedule services. So if you're in an APM, the increase would be 0.75%. Under MIPS, it would be 0.25%. So basically the fee schedule is going to stay very stagnant. Now, that may not seem like a big deal, but think about your costs of practice now and what your practice costs are going to be 5 years from now, or project forward to 2019 and then through 2026. Think about staff salaries, overhead, rent, mortgage, cost of patients, of your patient care is going to be driven higher and higher. So even if you stay in a neutral track, each year you're going to be making less money because that money is going to be worth less. It's going to devalue. And so it's not going to be a positive thing for you to be in that neutral payment track. However, in 2017, for this first year of MIPS participation, you're going to get to choose your pace of how you want to participate, whether you want to participate minimally or if you want to participate all in for the entire year. And we're going to talk about that in just a couple of minutes. But for eligible clinicians, okay, you can participate in MIPS as an individual or as a group, and there are going to be different different reporting requirements if you participate as an individual versus as a group. And I would say that most DCs are going to want to participate individually. However, if you are a larger group practice, and let's say you're listening in and you have 3 or 4 associate doctors that are working for you, you may want to consider participating as a group. And one of the things that we're going to do when it comes to the actual implementation is I'll be having this conversation with each of our clients individually. We'll be scheduling a call to decide how you want to participate in this, okay? One of the things that is underway with Medicare is the establishment of virtual groups. And the virtual groups, we don't have a lot of information on that yet. There already are a few virtual groups for dialysis centers and for family practice doctors who fall below the Medicare threshold as an eligible physician. And so what a virtual group would allow you to do would be to participate in this virtual group, and the combined numbers of the virtual group would make you eligible for the MIPS positive adjustments. And so as I get more information on these virtual groups and whether there will be virtual groups available for chiropractors, then we will, we'll have more discussion and more update on that. But right now, for year 1, you're either going to be more than likely participating as an individual, or you're not going to be participating at all because you fall under the low volume threshold, or because you're in your first year of Medicare enrollment. Let's see. Okay, so the quality payment program is going to start January 1st, okay? And you can begin collecting your performance data. If you don't start January 1st, that's okay. You're going to be able to pick your pace, and you can start anytime between January 1st and October 2nd of 2017. All performance data will need to be sent in by March 31st of 2018 in order to qualify for a MIPS positive adjustment in 2019. Okay, so this is your timeline for implementation, is any time between January 1st and October 2nd. Okay, you can also pick your pace. You can choose not to participate and just say, you know what, I'm just not doing it. And if that's the case, then in 2019 you would receive a negative payment adjustment. You can also submit 1 day worth, if you submit at least 1 day worth of data within the MIPS program, then you would avoid the negative payment adjustment and be placed more than likely in the neutral payment track for 2019. If you submit a partial year, you may, which is 90 days, you would of data, then you would receive maybe either be placed in the neutral payment track or receive a small positive payment adjustment. And if you submit for a full year, then you would be eligible for the maximum positive payment adjustment. Okay, so if you don't send in any data in 2017, then you're going to receive a negative 4% payment adjustment, okay, unless you are within the low volume threshold exemption, okay. You can do a test submission, which is, again, is 1 day, and that would be a very minimum amount of data to Medicare. You can avoid the downward payment adjustment. So really, Medicare is giving us all of 2017 to figure this out. There's really no reason for anybody to receive a negative 4% payment adjustment because their requirements for reporting are so liberal within this first year. If you submit a partial year, 90 days of data to Medicare, you may earn a neutral or small positive payment adjustment. And if you do participate for the full year, you may earn a moderate positive payment adjustment, which they are anticipating to be the 4%. Okay, so the question is how do I get scored? How do I get this score? And what's going to happen is all of the reporting that we currently do now is going to be reported just a little bit differently, and it is going to be reported under really this diagram shows 4 weighted performance categories, but it really is only going to be 3. And the 3 are going to be the quality component, the clinical practice improvement activities, and the advancing care information. The resource use represents the value-based modifier, and that is always that's never been a reportable measure. It is just through claims and through claims mining data that they come up with that value-based modifier. And so the same reporting is going to be required in 2017 that you have been reporting on all along if you have been participating in PQRS and meaningful use. And I know that there are some of you listening in who have not, okay? And so what we're going to have to do is we're actually going to have to really start from the beginning and get you on board with electronic medical records and with the quality reporting measures and understanding how to do that. But for those of you who have been doing your reporting, you're not going to see a huge change. There are going to be some differences, but it's not going to be huge for you. So it's something that you'll have already been used to doing. Okay, so you don't have to worry nearly as much as the physicians who are really starting from scratch in 2017 in order to avoid those negative downward payment adjustments. So here's how it's going to look. So what's going to happen is the quality component of MIPS, of the MIPS composite score, is what we now know of as PQRS, okay? And that is going to represent 60% of your composite score. The resource use and the advancing care information, which was known as the value modifier and EHR meaningful use, will represent 25% of the composite score, and a new category that has been introduced called clinical practice improvement activities will represent 15% of your composite score. So really the only thing that's new for those of you who have been participating in PQRS and meaningful use is the clinical practice improvement activities category. For those of you who have not done PQRS and meaningful use, you'll essentially be starting from scratch, and then we will have to determine the type of reporting that you would need to do based on where we go from here. Okay. Under the quality performance category, it used to be for most physicians, and we know for chiropractors we've only had to report 2 measures, is that you'll be selecting 6 measures instead of the 9 that most physicians had to. Include 1 cross-cutting measure and 1 outcome measure or another high priority measure. And you would select from individual measures or a specialty measure set. And for us, we will be working with the specialty measure set, and that will be the physical medicine specialty measure set. And so basically what we're going to do is we're going to look for those PQRS measures, so to speak, and within the specialty measure set for physical medicine, and those will be the ones that we would choose for our MIPS reporting as chiropractors. Okay, and really, PQRS, one of the things that they're really looking at under the MIPS reporting system is they're placing a higher weight and a higher emphasis on outcome measurements. And so I'm going to actually show you a couple of examples of that under PQRS here in just a few minutes. Under the advancing care information category, which represents 25% of your MIPS score in the first year, for this category you will be required to use certified EHR technology, And then you would choose to report a customizable set of measures that reflects how you use the technology in your day-to-day practice, with a particular emphasis on interoperability and information exchange. One of the things that you're going to see very clearly within this advancing care information category is that they are focusing very, very much on patient engagement within the EHR system, i.e. utilizing a patient portal to access records, utilizing secure email for patients to be able to email questions to the doctor, and so on and so forth. And many practice management programs already have this technology built into the EMR and into the practice management system. And so, you know, it may be that you already have this, but you're just not using it within your practice. And so by utilizing some of this, not only will you be able to score within the advancing care information category, but it would also count toward clinical practice improvement activities, utilizing the patient portals and health information exchanges and so on and so forth. So the way the advancing care information category is going to work is that the score is going to be made up of a base score and then a performance score. So the base score, I want you to think about it in terms of what do we have? In other words, do we have EMR? Okay, and is our EMR, HIPAA compliant? Do we have the ability to protect patient health information? Do we have patient electronic access, i.e. do we have a patient portal within our EMR? Do we have e-prescribing, which obviously does not going to, apply to chiropractors? Do we report to a public health clinical data registry, which again is not going to apply? But the base score is going to account for 50 points of your total advancing care information category score. And there are enough points for chiropractors within this section of the advancing care information score for you to get your total 50 points, even if you don't do e-prescribing. So the nice thing about the advancing care information and the quality measures that you're going to be reporting is that it's no longer going to be an all or nothing situation. What you report is going to be weighed and measured for that composite score. The performance score is basically, yes, we have, under the base score, it's, yes, we have this technology. The performance score is going to be attesting to whether you use the technology. In other words, do you use a patient portal on a regular basis? And you would attest to that in order for you to receive points towards the performance score, which represents half of the advancing care information score, which represents 25% of your total score. So I don't want to get you all muddled up with too many numbers, but just know that under the meaningful use component of it, and so if you want to think in terms of meaningful use and EMR, that's the advancing care information category now under MIPS. You're going to have opportunities to not only attest to the fact that you have EMR, but how you're using the EMR in order for you to determine your score. Under the clinical practice improvement activities category, this is going to account for 15% of the MIPS score in the first year. For this category, MIPS will reward clinical practice improvement activities, such as activities focused on care coordination, beneficiary engagement, and patient safety, which clinicians would select from a list of more than 90 options. I was actually scrolling through the options of clinical practice improvement activities, and guess what I found on as one of the activities was a spinal care class. So if you do spinal care class, you'll be able to attest to that under the clinical practice improvement activities category, and it's a highly weighted score that would count as a clinical practice improvement activity score, because that is that would count under beneficiary engagement and patient safety. Okay, so clinical practice improvement activities, again, when we actually do our individual calls, we're going to have that discussion as to which clinical practice improvement activities are you going to target for this score for 2017. Okay, and this is just gives some examples of the different types of categories of clinical practice improvement activities. One is called expanded practice access. So you could attest that you have same-day appointments for urgent needs, which most of us do. Most of us have new patient time blocked in our schedule for for emergency new patients. After hours clinician advice, and that after hours advice could be through a patient portal that would be available to the patients 24/7. Population management, probably not going to be a category that would apply to chiropractors. Care coordination might. So if you are doing care coordination with a primary care doctor, you coordinate your test results, or if you send reports to the family practice doctor, you will be able to attest to that through the care coordination component. Beneficiary engagement, again, would be things like safety programs, diabetes care programs, nutritional care programs, back care programs, and so on and so forth. That would fall under the beneficiary engagement. And I actually find this pretty exciting because these are actually activities that can improve your practice and make you more profitable. So, we've done a lot, in practice management over the years, we've done a lot of studies of, of patient retention when they take a spinal care class versus when they don't take a spinal care class. And we know that patients who attend spinal care class have a much higher retention rate and become better and more compliant patients. And so the fact that Medicare is going to actually reward this, I think, is a great thing. And other insurance companies are also following suit with these clinical practice improvement activities. So the question it becomes, how are we going to report? And we're going to be reporting in a number of different, there are a number of different ways to report. It's going to allow for third-party reporting, including registries, qualified clinical data registries, health information technology developers, i.e. your software vendor, and certified survey vendors to act as intermediaries on behalf of clinicians and submit data for the performance categories. There are certain quality measures that will also have the option to report via claims, but not all of it, okay? And so your PQRS measures, which are now going to be called your quality measures, or the QPP, you will more than likely be able to report via claims because those measures have not really changed. Now the question is, should you report as an individual or as a group? So here's the difference. So if you send your MIPS data as an individual, your payment adjustment will be based on your performance and yours alone. If you you'll send your individual data for each of the MIPS categories through an EHR registry or a qualified clinical data registry, or again, the quality measures could be sent through claims if those quality measures are available to go through claims. If you report as a group, you would submit your data with the group, and the group gets one payment adjustment based on the group's performance. Your group will send in group level data through each of the categories through the CMS web interface or an electronic health record registry or qualified clinical data registry. One thing you need to know is if you report as a group, you cannot report via claims. Okay, you would have to report through the CMS web interface or some type of a registry or your EHR. Okay, and so that's important for you to know, is whether you would want to report as a group. One of the one of the challenges to reporting as an individual if you have multiple doctors is that is going to be a bookkeeping issue, and that's going to be where, you know, you may have 3 doctors or 4 doctors working in the practice. If you report individually, you may have one doctor that receives a negative payment adjustment because of non-reporting or non-compliance, one doctor that receives the full 4%, one doctor receives 2%, one doctor receives, you know, a 0 payment adjustment. And so it will make posting payments much more difficult, and it will make setting up your fee schedules more difficult if, you know, once this all kind of takes place. So some of you are already experiencing that with the 2%. You know, you may have multiple doctors in your practice and you have one doctor being reimbursed at a different rate than another because you had one doctor reporting and one doctor was not reporting PQRS and meaningful use. So, you know, this is already happening, but it will be even more, you know, more stark as we move into 2019. So this is going to be something that, again, individually, you and you as the client, your biller, and myself will all have we will schedule a conference call to decide how, you know, what the game plan is, because I want everybody on the same page. I want the billers to understand what you're doing. I want you to understand what it is you need to do, and make sure that we're all you know, following the same suit. So under the quality category, most participants, and again, for chiropractors, I don't believe it's going to be 6 measures. I think it's going to be your 2 measures, including an outcome measure for a minimum of 90 days in order to receive any type of a payment adjustment. If you're reporting as a group, you would report 15 quality measures for a full year. And again, I don't know how that would affect at chiropractic if you report as a group, and it may be that chiropractors can't report as a group due to the fact that you have to report 15 quality measures. Under the clinical practice improvement activities, most of you would attest that you completed up to 4 improvement activities for a minimum of 90 days. Groups with fewer than 15 participants would attest that you completed up to 2 activities for a minimum of 90 days. So, you know, the clinical improvement activities category is going to be fairly minimal as far as what you need to report. But again, this part of it could actually have the most significant impact on the profitability of your practice. So here's how the pie looks. You know, the quality portion of this you know, is going to be represented by what we know of now in the green section of the pie. You could, and I will be sending everybody a set of notes, okay, for this. Please just, if you are on the call, send me an email letting me know you were on the call so I can send you a set of notes. But this green piece of the pie you can call PQRS, even though it's not going to be called PQRS anymore in 2017, but this is what we know of as PQRS. Under the advancing care information, which was known up until the end of this year, will be known as meaningful use, and then clinical practice improvement activities, which is the orange section, is the new category of practice improvement activities. So let's just, here's an example of a quality measure under the QPP. So this is one that we use now, which is the pain assessment and follow-up, okay? And if you pull this up on the QPP section of the Medicare website, it will tell you a lot of information. First of all, it tells you that this is a high priority measure, which is good because one of your measures must be a high priority measure. It tells you how you can submit this data, which is through claims or registry. It tells you that it's part of a specialty measure set, which is physical medicine, okay? And so it's important for you to know some basic information about the measures that you're going to be reporting on, okay? Here's another one, and basically this is kind of the white paper or a part of the white paper on the measure, and we know this pain assessment and follow-up as measure 131, okay? And it gives you the criteria for that measure, and actually if you get the full paper, the full white paper explaining how to qualify for this measure, you know, you'll be able to report this measure on a regular basis, okay? And again, and it gives you documentation instructions and so on and so forth that would allow you to report this as a quality measure. This is just a part of the full white paper, okay? Here's the other measure that we do in chiropractic, which is measure 182, which is a functional outcome assessment, okay? And again, there's a full white paper on this that explains clearly how you would qualify to report this measure. And this measure, it can also be reported through claims, and it also can be reported you know, as a G-code through the claims. Here's an example of an advancing care measure under the quality payment program, okay, and this would be the measure ID. The objective name is patient electronic access. Is this a measure required for the base score? Yes, it is. So if you remember, under the base score, it's 50% if you have this available, and 50% of whether you utilize it. It gives a performance weight of up to 20% of the total base score. Okay, participation in population health research. These are some other examples of clinical practice improvement activities, use of telehealth services that expand practice access. So each measure that you report has an activity ID, and it will allow you to report that measure based on the minimum requirements in order for you to receive that composite score. So, in summary, for implementation year 2017, DCs, you are considered eligible clinician, okay? MIPS and quality payment reporting will only be required for Medicare Part B patients in 2017, okay? MIPS and quality payment reporting in 2017 will affect Medicare Part B payments and payment adjustments in 2019, and it will be a positive or negative 4%. For 2017, how will you be paid will be based on your participation in PQRS and meaningful use in 2015. So if you participated in 2015, then you would receive a positive payment adjustment in 2017. If you did not participate, you would receive the negative 2% adjustment. PQRS meaningful use participation in 2016 will affect payments in 2018, okay? If you are a DC and you meet the low threshold exemption, or you're in your first year of Medicare eligibility, you will not be required to do any reporting. But again, remember that in 2019 you would not receive any type of an increase. You would just be placed in the neutral payment track. Okay? Here are some resources for you to have, and again, I'll have all of this available to you. This one, the link to the educational tools regarding MACRA and the QPP, is really quite good because it gives you a whole bunch of places that you can go for additional information on the quality payment program and education on it. There's a full white paper on the QPP that you can access online, and there's a QPP service center that's available to help you. There's a toll-free number, and they're available Monday through Friday from 8 a.m. to 8 p.m. Eastern Time. And so if you have questions about the quality payment program, you can contact the help desk as well. And of course, I will always be available to you as a resource, and you can always contact me for additional information, or if you have questions, I can help you research it. Okay, so what will happen next is that I'm going to conduct several follow-up webinars in January and February to review some of the specific reporting requirements as I get more information on for instance, what I may be doing is I may have a webinar just for ChiroTouch users to discuss how ChiroTouch will help you with the reporting requirements and that type of thing. So based on the software program that you have, we're going to do some research into your software programs to see if your software programs will support you in the reporting requirements. If not, we'll have to discuss the methodology for reporting for yourself, and as such, we'll be scheduling individual client consultations with you and your biller to go over implementation details and determine eligibility and reporting options and assist you in choosing your correct measures for all the categories. So that's going to be the next step to this. And of course, at the end of this, I'm going to open it up for questions. And I'm giving, I basically wanted to get through the actual presentation in about an hour, which I think I've done. And I have a full half hour for a Q&A. And we can use all of it or we can use just a small part of it, but really and truly, if you've got questions or you're just not understanding this, I would like, I'm going to open up the presentation for audio for you to ask any questions that you might have right now. I do want to just talk a little bit about how MACRA is affecting commercial claims and carriers before we actually open it up. We've all heard that as Medicare goes, so does the rest of the insurance industry, and this is no different. Commercial carriers are already introducing programs and policies that will tie reimbursements to quality care. And commercial carriers already are and have been for a while tiering physicians and in particular DCs. If you look at Optum Health and United Healthcare, they're a prime example of that. If you participate in United Healthcare, you know that Optum Health handles the pre-auths for United Healthcare. And if you have been with them for a particular amount of time, and if you fall under their practice, within their practice parameters, they will place you in various tiers of participation. And if you are placed in the top tier under Optum Health, then you're no longer required to submit pre-authorizations under Optum Health, which is, a great thing. But here are some other examples of things that are happening and are coming down the pike. Blue Cross Blue Shield of Texas has initiated a program called Bridges to Excellence. And you can become a Bridges to Excellence recognized physician if you provide programs for asthma care, cardiac care, or diabetes care. And the reason why I am actually showing this slide is I know that this is a presentation for DCs, but within our clientele, we have multidisciplinary clinics where there are physicians. And so Blue Cross Blue Shield of Texas is introducing this, and I know that other Blue Cross, state Blue Cross programs have similar programs. And so what Blue Cross Blue Shield of Texas says here is that they're inviting physicians who treat patients with diabetes, cardiac, asthma, or inflammatory bowel disease conditions to become BTE recognized and have opportunity to earn annual incentives for providing excellent care based on the guidelines. And they are going to pay a BTE recognized physician between $100 and $150 per patient per program year. So, we actually do billing for non-chiropractors, and I have an internal medicine doctor who's very excited about this because he sees all of this. He sees, asthmatic patients, he sees diabetic patients, patients with IBD, and he probably has 300 patients that are going to be eligible for this. So he is working on credentialing as a BTE recognized physician, and if he does, think about this, $100, even if it's $100 per patient times 300 patients, you know, that's a $30,000 bonus that he's going to get from Blue Cross Blue Shield for just being a BTE recognized physician. Okay. Cigna has, you know, basically, if you look at the Cigna Network News from July 2016, it says here, we want you to have the latest information about our quality initiatives and health management programs. Care guidelines and utilization management. We hope you'll find all these resources helpful when considering care options for your patients with Cigna coverage. Okay, they already have these programs, and one of them is called Care Allies. And it says here, custom solutions to support the transition to value-based care. So I'm just telling you right now, if you don't understand and if you don't grasp the concept that the way you practice is going to be tied to measurable quality values, you're going to be missing the mark, and you're going to find yourself kind of left in the dust from the standpoint of reimbursements and your ability to continue to receive increases in reimbursements within the insurance industry. Here's another one that I wanted to bring to your attention that is very important because I believe the majority of our doctors do accept Humana patients and Humana Medicare Advantage. This is a new compliance program requirement for healthcare providers. If you're going to be credentialed with Humana, you must attest to having a compliance program. Okay, and so so you're going to be required to do some type of an attestation or some type of compliance training through Humana. Ashen also requires this, that you attest to having a compliance program, and you know, and this is coming down the pike. So compliance, making sure that you all have compliance programs established within your practices is going to be huge. And this is another conversation that we're going to have individually to make sure that you have a solid compliance program within your practices. And we'll be talking about that individually as well. And I'll be doing more compliance talks throughout this next year for all of the clients, and you know, and having more webinars regarding compliance and compliance implementation. Humana, you know, also here's just another, you know, like practice improvement activity. Humana is requiring, and actually this is a new requirement under the PPACA. We don't know how this is, whether this requirement is going to stand once President-elect Trump comes into office and either repeals in total the PPACA or leaves components of it intact. We really don't know what's going to happen yet, but the PPACA has a provision that requires you to provide translation assistance at your cost to patients. I don't know if you know that or not. And you can actually receive significant fines and penalties if a patient complains that they were not provided that service. Humana and other insurance carriers are now requiring this as well. The good thing about Humana, and I've looked at Aetna's policy as well, is they actually provide those services. They make those services available through the internet at no cost to the patient, which is a good thing. But essentially, this requires you to have oral interpretation services, including American Sign Language, okay? And that you need to have posted in your clinic a notification of the availability of oral interpretation services. And these are going to be credentialing issues. So if Humana comes to your office to do a credentialing inspection, they're going to want to see that posted in your office, that you have oral interpretation services available to patients. Okay, and by the way, under the PPACA rule, they basically say that a relative is not qualified to be an oral interpreter because they could interpret it incorrectly or say whatever they want and you wouldn't know. So anyway, this is something that is definitely coming down the pike that we have to be aware of. Okay, so what I'm going to do is I'm going to open this up now, and let me just go ahead and just place this up here. I'm going to open up my menu. Okay. A couple of questions. Let's see. I'm going to go through the questions. I'm going to unmute everybody first of all. And then I'm going to go through the questions here that came about. Let me see. Let's see. This is from administrator, so I'm not sure who who this is, but that's okay. You can remain anonymous. We are still paper notes and have not reported at all. Okay. We're going to start reporting on claim form, but was told that we need a qualified registry. Where to find such a place? I have no idea where to start. And then, do we need to register, or can we just bill G codes? Okay, that's a good question, and the answer to that is going to we will need to have a individual conversation with you, and you'll just need to let me know who you are, and we'll schedule a time that we can find out whether you can report through your you're going to start reporting through your EMR program. If you're on paper notes, we're going to have to get you hooked into some type of an EMR program that allows you to either do your reporting through the EMR or through the registry. The only thing you're going to be able to report, as far as I know, the only thing that you're going to be able to still report through claims are the 2 quality measures. Okay, and I pulled up the list of quality measures, and the only 2 under physical medicine are the same 2 that we see now under PQRS. And so the answer is probably going to be a little bit of both. You're going to need to report under the quality component under claims, but the EMR component, the advancing care information, and the clinical practice improvement activities are going to have to be attested in a different way. Those aren't available to report through claims. Okay, so hopefully that answers your question, and we can figure out exactly how that's going to be done on an individual basis per client. So I have unmuted everybody. Those are the only questions that came. Oh, okay. Okay, Ida, we'll go ahead and schedule something. Okay, so thanks for letting me know who that is, and I'll get with you individually, and we'll get going on that. We'll also have to decide how you're going to report as far as group or individual, because you have multiple doctors. So okay, so we're open for questions. Do we have any questions at this point that anybody wants to voice? Yes, no? Any comment? Okay, don't be shy. Okay, for those of you who may be too shy to talk, you have my email address, goldstarmedical@msn.com. Send me an email. Also, if you were on the presentation, please send me an email so I can send your notes to you, and I thank you guys for your time. I hope all of you have a blessed holiday, Christmas, Hanukkah, whatever you practice. I hope it's a blessed time for the rest of the year, and looking forward to really going full steam ahead with you in 2017. Thanks, everybody, and have a great day.